starting out, we've had, we started fairly strong doing this human islet isolation webinar series. This is only the second one this year. I think we had a very good discussion by Bashu Nizaruddin from Baylor on his work on TPIAT. And I think I'm going to make an attempt this year to refocus to do more of these, at least 4 this year. And the reason for this renewed emphasis is what you'll see in this presentation. The ISO 20399 standard, which was published in 2022, emphasizes the need for process control. I wrote a commentary several weeks ago in our newsletter and stated that the reason why we need renewed focus on enzymes is because that is the only thing at this time that you can control. And until you start controlling at least one controllable factor in the process, it's a beginning. Because you can't make improvements to a process unless you've got, I believe, control of and understand the interaction and the characteristics of the enzymes with what you're getting out in the end. And so when I wrote this commentary, I stated that, the real field for these enzymes couldn't have developed without Camilla Ricordi coming to Boehringer Ingelheim Biochemicals in 1991 and really making a request to senior management that they should fund the Liberase project. And they heard what he said and they funded the project. I think that was a real advance that probably wouldn't have happened had he not visited Boehringer Ingelheim at that time. What I'm saying now is that VitaCyte, we're poised to do the same thing. I mean, the field's moved on, but we have enzymes, and all we would want to do is, if somebody has ideas that they want to do a study, that we talk about it and state goals, and we'll provide the enzymes to do this work. But I think the field's at a crossroad in 2 areas, as I write in the commentary. One is young donor islets. The predominance of organ donors now worldwide are young donors unfortunately, because of the opioid crisis. The problem with young donors is they have a different extracellular matrix, so the enzymes that work for older donors result in getting embedded islets from the younger donors. The embedded islets, you can't purify or recover those islets. So we need enzymes to do that. Also, for TPIAT patients, total pancreatectomy, islet autotransplant, it's clear the more islets you transplant, the better off your results are, that the more higher likelihood, I should say, that the patient is going to be insulin free. That's another area that's critical where enzymes could play a role. So to this end, I talked to Bala after I was getting ready to do this webinar, and he's agreed to present a webinar in Q1 of 2026, which would be entitled Overcoming the Challenges of Islet Recovery from Young Organ Donor Pancreata, an update 5 years later. He was the one that gave the first VitaCyte webinar, and he's going to now update feedback he's gotten from a method he's published a number of years ago, and see if we have further discussions on that. So this prolonged introduction, I will start the presentation. So the outline of the presentation is why standards, why now? I'll go into the importance of understanding how collagenase and protease mixtures dissociate tissue. I'll have a brief discussion about the 2 standards for ancillary materials, the USP 1043 and the ISO 20399. But more importantly, the change control portion of the ISO 20399 is pretty specific, and I'll use a case study to illustrate basically when this isn't followed, what problems it could cause and did cause in the clinical Islet Transplantation Consortium clinical trial, and have conclusions and the Q&A. So why standards one now? It all starts with in 2013, Japan's parliament, the Diet, passed an Act of Safety and Regenerative Medicine Act that loosened the regulatory requirements for stem cell-based interventions in medical practice. In other words, the preclinical data could be used as the basis for start actually applying these treatments in Japan. Of course, at the end of, I think it was 7 years, you had to go for formal regulatory approval. But the whole point was Japan wanted to get into the regenerative medicine area. So in 2016, the US Congress passed the 21st Century Cures Act to streamline the regulatory processes for regenerative medicine therapies. And as you can see from this quote, the whole thing that what they wanted to apply now is having people follow standards to simplify the paperwork and approval of these new therapies. Why do you want to have use standards? First of all, as shown by this guidance in industry, the FDA will recognize selected standards. So in other words, if you follow the standard, in essence, you may have to write a paragraph instead of a number of pages if you follow an accepted standard. But the important thing is it's encouraging collaboration, facilitating innovation and product development, and so forth. Regulatory review is easier. You now have standardization of methods for the manufacturers, and ideally it should support new therapies. As you can see at the very bottom, as part of this whole 21st Century Cures Act, there was a standards committee formed. And basically, if you click on this link, the Regenerative Medicine Standards Portal, they actually make each year a list of all the standards you can reference in regenerative medicine. So the whole standards, of course, is aligned with quality by design. And this is the definition, where it really is just taking what's been known in good quality practice and applying it to a pharmaceutical development. So the essence of the ICH-Q8 is that the quality cannot be tested into product. It has to be designed into products. And to be frank, when I was in Japan, it harkens back, as you can see on the left side, the quality of the design wheel, it harkens back to what was done in the 1950s when Deming, Juran, and others came to Japan to build up the industry in post-World War II Japan. And it's the plan, do, check, act cycle. And this has been the found cornerstone of the Toyota production system. And in fact, the how Toyota, which is the leader, so to speak, in applying quality into all their products, still practices this common method today. The whole proponent of this is this was a revolutionary approach in manufacturing that eliminates waste. And the whole point is, Taiichi Ono says in this quote, you can't improve a process without starting off trying to standardize it. So the whole thing, and the other thing that it means is that you really have to have everyone engaged. It isn't like people who are sitting away from the process of making recommendations, you're going to have the users actually give feedback of what they think they can do to improve the process. And in fact, this is the big difference in why Toyota became the quality leader. They had the workers, actually, the people on the line, really be very engaged in the manufacturing process versus the GM, where it was actually the engineers, efficiency experts, that were driving this process. And now, of course, everyone has developed this Toyota production system model worldwide and in a number of industries. So the whole point is process control drives quality by design. So you have to first start with quality target product profile, a QTTP, for the cellular product that defines the characteristics of a product that will meet customer needs. And it's you have a starting input materials, which are critical material attributes, into a critical process parameter for what we'll get into shortly. You have collagenase protease enzymes going into the tissue. The critical process parameter is tissue dissociation, and the critical quality attributes that come out of the products is your cell yield, cell function, cell viability, and whatnot. So in essence, of course, it isn't just tissue dissociation, but there are a number of critical process parameters and critical material attributes that you have to consider. So if we take a dive down into kind of a value chain of how these processes are done, well, it starts with organ procurement and transport. You get into tissue dissociation. You then have to, as we do with islets, you have to isolate the cells, and for allo islet transplant, you do short-term cultures. You then characterize the cells. Do they pass the release criteria? Then you may have to ship the cells. Or for whatever application, if you're doing research, it has to be consistent with what the end user uses, for example, human islets for research studies. So our focus is going to be on a critical but controllable critical process parameter, which is shown in this second value chain. The actual steps in the enzymatic tissue dissociation, where in fact you prepare the organ with an enzyme solution injected into the pancreata. You monitor the tissue dissociation. You then stop the digest, and at the appropriate time, harvest the cells and wash the cells, and then do cell isolation and culture. Why is the enzyme really important? It's because of the speed of digestion, cell yield, viability, recovery. If at the time we want to do cryopreservation, it's also going to affect recovery from cryopreservation. So before we get into the whole issue of this, I wanted to stop and go through collagenase protease mediated cell isolation. And I wrote a blog post a couple of years ago, and saying that we developed a hypothesis or a model of how these enzymes work, and it followed Occam's razor. And it's just using a simple explanation of how these enzymes work, and is that a useful tool for you to decide what enzyme, what concentrations and doses and types of enzymes you're using for tissue dissociation. So it all begins, to give you just some background, I'll show you a 2-minute video shortly of a medical animation we did to showing the mechanism of action. But in essence, the important thing to realize is that we now know the C histolyticum collagenase gene structure. There are two classes or two isoforms of collagenase. A class 1, which has, as you can see, two collagen binding domains, and a class 2, which has one collagen binding domain. Functional collagenase, ones that, and you have to realize the true function of collagenase is to degrade collagen. They have to have most of this molecule, at least one collagen binding domain and a catalytic domain to efficiently degrade native collagen. If these collagen binding domains are lost, in fact, the enzyme's non-functional. It can't degrade collagen, and you'll be seeing why very shortly. So this is a schematic that I got from Josh Saccone, which shows you that even though these two isoforms of collagenase, class 1 and class 2, and here it's class 1 is col G and class 2 is col H, they act in different ways. Class 1 or col G is actually shaves off one tropocollagen molecule at the time, and you'll see this in the video I'll show you shortly, whereas class 2 or col H is actually an endoprotease that makes cuts to the collagen fibrils. You have to realize that in general, collagen is extremely resistant to proteases. That's the beauty, or otherwise we'd be having real problems in maintaining health if we didn't have protease resistance collagen in our tissues. So why is this important? Just it's to remind everyone that in fact the only true functional assays of collagenase are those in which have collagen binding domains. If you don't have a collagen binding domain, you can't degrade collagen. So what it really shows is the only true assay is collagen degradation. The gelatinase assays or the Wunsch or Falk assays that are commonly used actually may not necessarily correlate with the ability of that product to degrade native collagen. So here's the, just step back, there's the 2-minute video that I'll start.
Maximal cell recovery from tissue requires the use of Clostridium histolyticum collagenase products that contain neutral protease activity. The mechanism of action of how these products work was unknown until 2011, when VitaCyte proposed a mechanistic model based on results from isolating cells using purified enzymes. Cells are entrapped or directly held in tissue by the extracellular matrix, a jungle of fibers and globular proteins. The predominant protein is collagen, which shields other proteins from proteolysis. Purified collagenase products loosen the extracellular matrix using collagenase and protease enzymes synergistically. Class 2 collagenase is an endoprotease that cuts collagen fibrils, while Class 1 collagenase finds these damaged sites and shaves off one tropocollagen molecule at a time. This leads to exposure of protease-sensitive sites on matrix proteins. Proteases in the collagenase product then cut these protein tethers, freeing the cells from the tissue for further processing and use. The critical factors of success are to use purified defined enzymes for cell isolation, use excess collagenase collagen degrading activity that has minimal adverse effects on cells, and select the appropriate neutral protease enzymes and determine the optimal amount of protease activity required for successful cell recovery. We have solutions to help you recover cells of interest. Learn more at VitaCyte.com.
And you can see that from that video that it's a pretty simple process, but I can tell you we have used these concepts and they work fairly well. And I want to thank Stu for giving me some slides on adipose stromal vascular fractions to see scanning EMs. And what I realized when we were developing this video, you really have a jungle. The cells are literally entrapped in a collagen fibril jungle, and you have to thin that jungle out as well as use the proteases to cut these tethering proteins. And until which time that's done, you will not get cell release. So this is going to play into what we'll talk about shortly in the case studies. So I'll just touch base on the ancillary ISO and USP ancillary material standards. Definition of an ancillary material is one that comes in contact with the cellular therapeutic product during the cell processing, but it's not intended to be part of the final product formulation. In essence, the two standards were the 1043 that was published this is wrong date. It was published in 2022, and the biotechnology, the other standard is the 1043 standard. I'm sorry, the 1043 was published in 2019, and here is the 2022 date for the international standard. So the 1043 focuses on a risk-based approach. The ISO 2039 is broader because it really emphasizes that there has to be a relationship between the ancillary material supplier and the ancillary material user. And you really need, what we find all the time is, we can make product any specification, but it's really what you need. And that's why we need guidance from users to know what the limits of what a good and bad enzyme prep are. And I'll be frank with you, no one does that. And the field is still evolving, but it's something I'm sure as we get into more commercialization of islets, likely with genetically edited pig islets, that has to be addressed to tighten up how these enzymes are being used and what dose and formulations. So here you can compare the two standards. This was in a blog post that Drew Bridey wrote a little while ago. It's on our website. But in essence, he compares the two standards. And the important thing here is documentation, manufacturing, characterization is all part of the ISO 20399 standard. So this is a more detailed standard than the USP, but both should be used in concert with each other. So the key element I'm going to talk upon in the case study I'm going to also discuss as part of this standard is section 11 of the 20399 standard. And what it says here, the key components, what's written in this standard, has to be quality agreements. You have to notify AM users when there's changes in the process, discontinuing manufacture, or changes in the manufacturing site. The important thing is here, you really need to understand the characteristics of your enzyme, because if that enzyme disappears, right, or isn't working anymore, you know enough about the biochemical characteristics, you could look for a comparable product. And I'll be frank with you, this is a challenge that the field faces. And all of us know the story of the problems with Liberase HI occurred when it didn't work the same way as it did in the beginning. And the important thing is that the ancillary material supplier, should be transparent and really be informing people if there is going to be a change. So I'm going to talk about this case study. And because of our lack of knowledge of enzyme, at the time around, it was 2007, 2008 through 10 or so, and what it led to. So it's when it literally occurred because Liberase HI was dropped as the enzyme that was planned to be used in the clinical Islet Transplantation Consortium clinical trial, and they switched to a Nordmark product. And the reason, let's face it, they switched to a Nordmark product because it had a GMP grade label. So it's it was a reasonable choice at the time, but at that time, there wasn't a firm understanding of the biochemical characteristics of the enzymes required to isolate islets. And I want to caution right now, this is a time when the field the manufacturers are still evolving. I can tell you, we analyzed all products from all suppliers in a publication in 2019, and the issues that I'll discuss with the Nordmark products no longer exist. They've improved their products such that you don't see the degraded class 1 collagenase that I'll show you at the time of 2007, 2008. So this is the timeline for really the use of collagenase in human islet isolation. And where it starts, of course, is collagenase P and Camilla Ricordi finding out this was the best product to use. This was where he came to Boehringer Mannheim and ended up in the development and launch of the Liberase HI product. The Liberase HI product was used in the immune tolerance network trials that were carried out in 2000. So it was the sole enzyme that was used at the time. Then there was a switch made, and this is where it gets to be important. The switch was made because, as I wrote in a review article several years ago, it's because there was a change in the column, and the people who were then manufacturing Liberase didn't understand what that change meant. So the collagenase didn't perform as well. So they went to the Nordmark enzymes. The problem, as I'll show you shortly, there were centers who could not get enough islets out of the Nordmark centers, very experienced centers. And that's why VitaCyte got involved having these people use our enzymes in place of Nordmark. Roche soon followed. There's now, of course, just to mention, there's animal origin free enzymes available also now. So what happened in 2000, this was the first time, to be frank with you, that we got direct feedback from all the participants who were going to be in preparing islets for this immune tolerance network trial before I left Roche at the end of 2001. And I remember sitting in a conference call where people were taking specific lots and saying that these characteristics were the best lots they got, and correlated certain lots with better yields. And in fact, this was the third change that was made in the Liberase product, but this one was actually based on input from those people who participated in the trial. The issue that they came up to in the 2000 trial is that only 44% of these subjects achieved the primary endpoint. In other words, could repeat the Edmonton protocol. But really, the success was significantly affected by previous experience at this site. In other words, the major centers that could do this were three centers, which was Edmonton, Minneapolis, and Miami, who had extensive experience in islet transplantation. So shortly after that, my guess is it was around 2003, because I was no longer at Roche at the time. Jonathan Lakey and his group in Edmonton adopted the biochemical analysis that was performed on the Liberase HI. And so they could independently analyze this. And what he found was a disturbing trend. He found that, in fact, what was occurring in these lots is you had the appearance of a new peak, a C1b peak, this green, and it made a higher proportion. You can see this in the crude collagenase here that we have in some marketing materials. As you can see, the original collagenase, this peak did not exist. Well, this, as I mentioned before, reflected a change in the column, and you're actually getting degradation during the manufacturing process. So at that time, John made these observations. Camilo Ricordi also, his group also made observations of problems with the inconsistency of the product. But at that time, NIH decided to fund the clinical islet transplantation consortium network trial. And, the purpose of the funding was really to increase efficiency of islet transplant with getting single donor transplants, improve immunotherapy, and do a phase 2-3 clinical trial so you could apply for FDA license. As I mentioned before, NIH forbid the use of the Liberase HI, which led to the Nordmark enzymes that were GMP grade enzymes. The problem, we were approached by Camilo and Bernard Herring, and the problems which we had already seen with these products was that there was a lot of degradation of the Serva Nordmark product. And you can see this is the line that would reflect the intact C1. This is the line would be the C1b and the C1c. I can tell you with the C1c, that's a lot of degradation of the class 1 collagenase when you see that high peak. As you can see at the time, the Liberase HI that used had more degradation, as John Lakey showed, and we were aware of what this meant because of our use of a collagen degradation activity assay, and we didn't include this peak in our fractions of our collagenase HA product. So what we found validated John Lakey's earlier work. This is consistent, as I said, with our collagen degradation activity assay, where you can see in this kinetic fluorescent microtiter plate assay, this is in the initial studies, that the intact had about a 10 times higher collagen degradation activity units per milligram than the single, and this had a double collagen binding domain, than the single collagen binding domains found in either the truncated, the C1b or C1c, or the C2 here. So there was a nice correlation now between collagen degradation activity and its effectiveness in islet isolation, as I'll show in the next slide. Whoops. Going backwards. Sorry. So this is just to show you what this assay looks like. I'm not going to spend any more time on it. But this is the work we did with Minnesota that was a paper published in 2010, where it shows, again, what I just reviewed with you before. And this is the correlation. So what Bala showed at that time is the digest time was longer, which was a significant difference, the post-purification IEQ total counts were higher with the VitaCyte enzyme than with the Nordmark enzyme. Post-purification IEQ per gram of tissue was higher with the VitaCyte enzyme versus the Nordmark enzymes. And just to let you know, this was the VitaCyte, which was equivalent to the Liberase HI product, which in those cases we used thermolysin. So I'll summarize 2 years later all of their work, and this is from 94 islet isolations. And what it showed and what his data showed is again confirmed if you have a high percentage of truncated C1 with C1b and C forms in them and only single collagen binding domains, you get low yields. If you use a high intact C1, like in the VitaCyte product or the Roche MTF product, that we even gave him some products with a very tight fraction with a lot of intact C1, you get better results. But in fact, the best results were when he switched from thermolysin to the C histolyticum neutral protease, the NB protease from Nordmark. And in fact, what you're finding out is that, and this mixture is still being used at Minnesota, it has a very good result. It's very good results. And so what it's telling you is selection of the protease with the appropriate dose, as well as having intact C1 when using a Ricordi procedure. I have to emphasize, it's really important to have that mixture to get the highest yield. So Camilla Ricordi published a report on the outcome from the manufacturing of human islets for the entire CITC clinical trial. And as you can see, the success rate was 52.5%. They did a total of 324 isolations. And most of the success rate really was dependent on islet yields in many cases. The predominant reason why the islet isolation was successful is because they recovered enough islets for transplant. This contrasted with the ITN trial, where it was 45%. You have to realize also at the time of the ITN trial, they did not culture. They used the islets immediately after isolation. Success rate varied. It shows you the importance of the experience of the islet isolators between centers. So it really speaks to the question that you have to really have experienced islet processing facilities to be successful in a large-scale application of this technology. So retrospective analysis from this clinical trial is a case study. The pros were a shared documentation procedure, and they had weekly meetings where they shared all this information. The cons were the most critical process aspects in human islet isolation, the tissue dissociation enzymes were poorly controlled. Organ selection varied between centers. There was one center that was higher than anyone else than to get islet yields that could be used for transplant, but they were very careful on selecting the organs. And of course, the cons are you still had differences in ability of different centers to isolate islets effectively. So the lessons learned reference to the ISO. Transparency is the important thing. Roche made a significant change in the manufacturing process that really resulted in an inconsistent product. And this was, believe me, the people at Roche knew about the problems they were having, yet key customers didn't know about it. Both the AM standards emphasize the need to implement rigorous and comprehensive qualification processes. I think that includes, ideally in the future, understanding more aspects, deeper understanding of the analysis of the importance of the biochemical characteristics of these enzymes. Good example is we still use a Wunsch assay to dose, when in fact I've showed you that the Wunsch assay can be misleading because it doesn't necessarily correlate with collagen degradation activity. So the whole thing is that there's an overemphasis of the GMP grade label, and the AM user experience is that not many people understand the importance of collagenase for human islet recovery because no subject matter experts exist in this field. And I think this is something, as I mentioned before, we're willing to work with anyone who wants to start making these correlations, because in essence, the field's not going to move forward till we get better science in this area. So our actions are to proactively work with users to supply the relevant information. We're committed to improve the education process. Webinars are a result of this. And we also, Drew, Brady, and I also are part of a presentation on the ISO 20399 standard that's being offered by the standards coordinating body. And it's going to be offered by the International Society of Cell Therapy training arm. And we've developed a recombinant collagenase, which is based on a design of experiment approach where we understood exactly what the importance of the class 1 and class 2 contributions are in human islet isolation. And that work was published in 2016. So focus of the company is to continue to improve and share knowledge, consistent products, so you don't have to lot qualify, and cost-effective products. We offer 3 different grades of collagenase, and really what our goal is to increase your productivity. So you're using the right enzymes for the right applications. So any questions? I think one of the issues that I can comment on that I think as the field is moving forward, I know there's efforts to, Paul Johnson is going to have an effort to standardize more islet counting, but I think the other issue that needs to be done is to have somebody start looking at the critical process parameters on islet isolation and start addressing those. Tatsuya, you have a question, please.
Okay, so my question is, collagenase is basically protein.
That's
so
correct.
My question is, can collagenase itself be digested or cleaved by protease?
Yeah, that's why it was created. That's right. Why the C1b and C1c were created.
Okay. So can I ask more?
Sure.
So collagenase is very specific to collagen. Right?
That's right.
So my understanding is that over digestion with collagenase would not usually occur because it's very specific to collagen.
That's correct.
So that means excessive amounts of collagenase is not harmful in terms of islet isolation.
As a rule, yes.
In contrast, excessive amount of protease is harmful.
Yes.
So is it right? My understanding is right? Do you agree?
Yes.
Okay, thank you. And
the The thing
Yes.
that we found out, though, the only caveat I would say, the only thing we found out when we did that study with you guys, actually, when you started adopting the recombinant, what was interesting to us was the difference in natural collagenase and recombinant collagenase, in the fact if you'd lowered the dose, what Doug's data is showing and your data is showing, then in fact you're getting, reducing the dose of collagenase, you're getting better function.
Yes, right. Yeah, right. Yeah.
Which is contrary to what that statement, but it still is, again, it's a rule of thumb.
Mm-hmm. Okay, thank you. And can I add more? So class 2 versus class 1 collagenase. So which is more stable during the storage and which is more difficult to manufacture? Class 2 versus class 1 collagenase.
They're probably, I will tell you the big difference between class 2 and class 1 is class 1 is very susceptible to proteolysis.
Okay.
It's very susceptible to proteolysis by clostrapane, which is a tryptic-like peptide that's secreted by C histolyticum. Best example, what I can cite, and this is no hard data behind it, but it makes all sense, is John Lakey, when he worked in Indianapolis as a postdoc, did a study where they isolated pig islets. And they did a timeline and studied the decay of the islet isolation ability of a specific lot of collagenase P to degrade over time. And in fact, in 18 months, it lost all of its ability to recover porcine islets. That's in a published paper. And what we believe is that collagenase P was also unique in that it had very high clostrapane levels. And we believe that what that really was going on was the clostrapane was degrading the class 1 collagenase. And it gets back to John's observations in 2005 with Matthew Barnett, I think his name was. So this is all consistent. So class 1 is definitely very susceptible. Class 2, less so. It isn't degraded that, it doesn't say it can't be, but it's more resistant, clearly more protease resistant. And the whole problem that we still don't know, and I will tell you, we did the paper with Minnesota where we did a design of experiment, and the product we now sell, the collagenase RHI, actually is in the midpoint of that whole design of experiment where there were four different buckets, and what RHI is in the middle dose between all those four buckets that we tested. But what we find is that there's really no difference in the ratios we tested. And yet we're talking one of Matsumo Goto from Japan, and he thinks that you should use more class 2. And I think you had a paper, didn't you, Tatsuya, where you thought that class 2 was more important or was less, or I can't remember. I know you wrote something on it years ago. So right now we don't know what the issue is on the class 2 and class 1. You can look at that mechanism and see that you probably have a wide range and flexibility of these mixtures, and it still work. The important thing is you really should be testing the protease first, and if you really want to optimize, find out what the right proteases and then go back and optimize the collagenase.
Okay, thank you. My last question, very basic question. So what BP protease, what BP stands for?
It's Bacillus polymyxum. It's the source of the protease. It was just, we had to name it something.
I didn't know that.
Huh?
Thank you. Thank you. I didn't know that.
Yeah, that's why it's called BP. And dispase is how do I want to say it? The issue with dispase is trade name.
Yeah.
It actually is trademarked. So you can't use dispase. It's part of Goto Sushai's trademarks. So we had to name it something else. And we call it dispase equivalent enzymes.
Okay. Okay. Thanks so much, Bob.
You're very welcome.
So Bob, can you hear me?
Yes.
Okay, so Stu here. Thanks for the presentation. I mean, there's a lot of information there to now chew over. One thing to go back to some of the things that Tetsuya was asking about, these documents that we get to suppliers and all these standards that have been coming out, a big part of this in my mind has been the recognition that the major people at risk for, besides the patients, for all these different enzymes and all these evaluations are the users. So we as users are trying to mitigate our risks by going to the suppliers of all these materials, but let's concentrate on collagenase. And what we have to go on is the documentation that we get from the suppliers, and then trying to compare those suppliers. And then what happens, so it's like a five-part question here. Then what happens is and I'll give it to you from my academic side. The academic laboratory, we receive this product, and some undergraduate, God bless them, I was one once, takes that enzyme, pulls it out of the box. It's Friday evening, and sets it out on the lab table and figures that Monday morning they'll come back in and do something with it. First part is the documentation that we get from the suppliers. Are there any efforts to try to standardize those? Because there's no way we can compare all these different enzymes just from the documentation.
And the answer is no. I was going to write a guidance standard, as you know, Stu, for collagenase at one time, Clostridium histolyticum collagenase. And the reason I stopped short of writing it is because there was no standard collagen degradation activity assay. And unless you can measure collagen degradation activity, all the other assays we use to measure collagenase are meaningless. So the best assays that you could use, to be frank with you, is probably the anion exchange chromatographic assay that's described in chapters 89.1 and 89.2 for class 1 and class 2 collagenase. Those are published chapters that were based, Roche worked with USP to write those standards and those assays and those materials. However, I should caution, just to let you know, those methods are the same methods we used for Liberase. So they were developed by Francis. But those are what we need is a collagen degradation activity assay.
Right.
And we have one in the cooker, so to speak, that won't be as nice as the fluorescent assay, but it works.
And if it can be done easily,
yes,
we might be able to avoid that situation that the academics laboratories have. They get a collagenase in, it's not stored correctly, it's left out, and we have no assay to determine whether something has degraded or changed. So what most investigators do, every bottle of collagenase, which is a mixture of enzyme, if it's a crude collagenase, every bottle we get, we use it until it's empty, especially those of us who don't have major amounts of money to buy collagenase directly from the supplier for every single isolation. So as the collagenase ages, you just tell the students to add more, add more, add more.
That's right.
And because we have no assay, there's no
That's
standardization to determine that it's just gone badly. But I'm sure you have the experience. I in my laboratory finally developed some more specific assays of the enzyme, and I get samples of enzymes from an investigator and find that the class 1 and class 2 collagenases were pretty much dead, non-functional. They had lost their binding capability, etc. But the enzyme still worked in order to isolate cells, not as well, but still works. So what people do is tend to add more enzyme as it ages.
See, I think this is the trick that I learned when we left islets and went to hepatocytes, and we supplied enzymes for hepatocytes. The big difference is you can actually use what the hepatocyte people don't use is they do not use a closed system. You have to realize that hepatocytes will digest 100, 150 milligrams of liver tissue and get hepatocytes out. Whereas if you use a Ricordi chamber, you're using over 400 to 500 milligrams. Why is that the case? It's been my belief that, in fact, a Ricordi chamber is a closed system, you're actually inhibiting the enzymes from binding.
Yes. Yep.
And if you do a flow-through system, a perfusion system for islet isolation, in fact, you could it's probably a better way to go, and you could more than likely use less enzyme. And in fact, that was shown by the people at the Rogerson Institute in Xenia, Ohio. They wrote a paper with I'm not on the paper, but Drew Brighty is and Mike Green, and they wrote a paper on that, in fact, showing that you don't have a closed system, and in fact, you can use less enzyme. And the other application, which I found out, was monkey islets. Jack O'Neill published a paper in around 2000, I think it was, in Cell Transplant, where he showed that you used a Godot-like procedure that you use for rodent islets, and you use it for monkey islets, and you don't. So you're digesting, you're putting the collagenase just like you would in a rat or mouse islet into the duct, and you're letting it sit in the enzyme solution. The amazing thing is they're using less enzyme. They're incubating, which is unheard of in a Ricordi procedure. They're incubating for 42 minutes. And in fact, the yields that they're getting out are 8 to 10,000 IEQ per gram. The best you can get in a Ricordi chamber is about 5,000 IEQ per gram in a monkey islet isolation. That's the best you'll do. So it just shows you we have so much to learn about how these enzymes can be efficiently delivered. And I think my own belief is you don't need to use as much enzyme. But if you want to continue to use the Ricordi procedure, you're going to use a lot of enzyme. And as you know, Stu, because I was bugging you when you were in academics, I wanted to always try to find somebody where he could radioiodinate the collagenase.
Right.
And we could find out what the hell happened to it.
Yeah, exactly.
Because, you know, I'll give you another instance. I will tell you, when we did the studies back for QFD with the Liberase, well, we found out no one used Worthington products. And of course, we know now the reason why you didn't use Worthington products, because they only have about 5%, 6% collagenase.
Right.
Whereas the Sigma product says higher collagenase. So what people have done is no one even used it for rodent islet isolation. Well, there was one group in Kansas City that did, and I'm convinced they wouldn't share the method with me, but I'm convinced that they probably used it as a flow-through system. So you flow the enzyme through, you don't get the inhibition. The collagenase actually is binding to the tissue, right? And you actually using the tissue as a way as an absorbent to stay in local area.
So, Bob, one last question for you. I mean, we focused a lot and you focused a lot in your presentation on the islets, and you know, I do a lot of my work in adipose-derived cells, and then there's hepatocytes, there's trabecular meshwork cells, lung, and all that. I mean, I will fully admit that the islet field, as far as understanding the enzymes and the isolation, has, I believe, truly reached this century, whereas the adipose field, as far as standardization, we're still back in the 1700s. There's absolutely no standardization that goes on. There's no way that you can compare one laboratory to the next laboratory, one clinical trial to the next clinical trial when it comes to the adipose world versus the islet world, which they do have standardized protocols. And I think you used the term that they shared documented procedures. But in the islet field, we're giving away some of the secrets here. My sense was, yeah, they had a common procedure, but everybody modified it slightly still at their own site. What can be done in this field? I don't know what VitaCyte can do or what we all can do to try to force some standardization of protocols. And then if here's a standard protocol and you've got this coordinating body that's trying to standardize, and then have people really state how they have gone off that standardized protocol in some way to try to bring adipose-derived cells forward, at least to the level of where islets are right now. I mean, with adipose-derived cells, after my review of, probably over 2,000 documents showing procedures, some of these people use the collagenase for 12 hours or more.
I know, that's ridiculous.
It's not 42 minutes, it's 12 hours.
I know.
They do it overnight, because that's the classic one. They put it together and then go home.
I will tell you, that's the reason we don't supply to academia. And they were doing B2B sales. And it's simply because the academia, if they get a protocol and this better than anyone else, you just hand down the protocol all the time. And we find this, to be honest with you, in rodent islet isolation.
Right.
I mean, there's the rodent islets, as a rule, the people who adopt use of our rodent islet product are the ones that are usually in pharmaceuticals. And leading labs do it too when they realize, it maybe it's going to cost you a little more, but you're going to get more consistency. I'm convinced the question you're raising has to come through by adoption of standards.
Yeah, I totally agree. It's going to be adoption.
And it's going to happen sooner or later. Like Drew Bridie is now on a committee which is the right question to ask, is how do you set a specification? We should not be setting specifications just on and let's face it, our specifications are based on our manufacturing history. That's what it's based on, because no one else can tell us how to set a specification. Ideally, what you want to do is have the user do a validation study, and they can decide what the appropriate standard for their needs. I mean, we've had products that have failed in one of our QC tests, which is really rigorous, and we go and offer it to, and this is, an adipose in dogs, and give it to them and say, one, you try it out. They have no problems when using the enzyme, even though it failed our specs. And we release at a lower price to them. But realistically, this is something that has to be done. And the way I look at it, and looking at this whole field, where that's going to happen is when pig islets come in. I can tell you, it's going to happen.
Yeah, it's going to happen there.
It's
Well,
too big of money. The
I
problem
will
with
tell
the
you one
human
anecdotal story. I helped a lab one time get into adipose tissue digestion and talked to them about 6 months later at a meeting. And they were very excited. They had developed this standardization method to use a colorimetric assay to evaluate the brown color of the enzyme. And when they mixed it up, I forget what wavelength that they were using, they would dilute it so it had the same the reading at whatever wavelength they were using. So that's how they standardized the amount of enzyme that they were using in each isolation. Which, you know what? At least it was standardized, so you could compare.
That's exactly wrong thing to measure, but
yeah, not good lot to lot, and it's going to be real problematic if they started using recombinant enzyme.
Yeah, and I think that's the whole thing. Why when how collagenase evolved, it was crude. The way I look at that field, it's crude collagenase. Then it was purified collagenase, and when I think the story in Roche, when they had a change in the manufacturing procedure in Nordmark when they first introduced, purified doesn't necessarily mean that it's really going to work.
Right.
You have to have purified. Why we created a new category, purified defined, is saying it's purified, but we also know what's in it.
Right.
And that's what you need. And that's when we're getting back to the ISO, why I embrace the ISO 20399 standard, is because you have to know the critical characteristics of that enzyme so you can find another vendor. And the business people, the only ones who are going to do that. But they really should be asking the question themselves, because my belief is probably for most procedures, you probably don't have to have intact class 1 collagenase. I can tell you right now, you can do a mouse islet isolation with only class 2 and it will work. You don't need class 1.
Yeah, that's a different matrix surrounding those.
Different matrix. Yep. Livers are going to different matrices. Adipose, as you know, more than anyone else, is a different matrix. You don't need the amount. And so the whole question is we've fooled ourselves by using crude collagenase to think that that's a good, that's the right amount, when in fact, you have to determine that with the purified components or a defined component. But I think the issue, if you will, of the issue of the importance of this whole model of excess collagenase isn't harmful. Hey, you have to modify your theory as the data gets generated.
That's right.
And I think, again, kudos to Edmonton, because the studies that Tatsuya and Doug are doing about showing how dose of collagenase actually impacts islet function is amazing. See, Bala didn't see that, but Bala used a much lower dose of collagenase. He saw a big difference between natural and purified when he was using 12 Wunsch units of our natural purified material. Tatsuya and Doug are they're matching it with the RHI product. That's 16 Wunsch units.
Right.
More collagenase. So what we know now, if you say Doug's and Bala are doing a similar things, what Bala's study says you can't use 12, but Doug in Tatsuya's work says you can use 16. But no one knows. Other than that, we don't know.
We don't know.
And in the data that Doug is published in abstracts has clearly shown also that there's better function at 16. And why is that the case? I don't know. But that's where you have to do further studies. Right? I mean, to me, I think it's you know, that's why I say I think this is going to happen in industry, and it's going to happen probably with pig islets, when genetically engineered pig islets, if they come to the forefront, because in essence, they'll have to know this. And you can't do it with human organs for a couple of reasons, and most of it is because the quality is so variable. You can't control it.
That's right. And there's no more animal studies allowed.
That's right. That's right. That's right.
In vitro veritas. It's going to happen again.
All right. Well, thank you for attending, and this will be on our website. And I wish you all a Merry Christmas, and I will let you know when Bala is going to give the presentation in Q1 26.
All right. Yeah, Merry Christmas. Thank you, Bob.
Merry
That was
Christmas.
great.
Happy holidays to all.
Take care.
Bye.